Good evening, friends and colleagues. It's an absolute pleasure to welcome you to the inaugural Dr. Stuart Saunders Lecture. We are here to celebrate the life of Stuart. Stuart graduated from medicine at UCT in 1953. He went on to do his postgraduate studies in London at Hammersmith Hospital and later at Harvard before returning home to read for a Doctor of Medicine degree, graduating in 1965. And like me, he took up his first substantive post as the head of medicine in 1971, a post that he held until 1980. When he went on to be the vice-chancellor of the University of Cape Town until 1996. As a head of Department of Medicine, Stuart has affected the lives of generations of doctors who, under his supervision, worked as interns, medical students, medical officers, registrars, and consultants, and many of whom are in attendance today to pay tribute to him. It was also during his leadership as head of department that he stopped the segregated training of registrars at the University of Cape Town, and the then late Professor Brian Kiss was admitted as the first non-white medical registrar at UCT. As Vice-Chancellor, he continued to lead with a great sense of principle and morality, and in fact, abolished the segregation at residences at the University of Cape Town. Something that we take for granted today. The principles of academic freedom were enshrined during his tenure, during a very difficult political time. And Stuart has written a memoir of his time leading in medicine and as a vice-chancellor. And amongst the many prizes and awards that he's received is the National Order of Baobab in recognition of his moral leadership in medicine. And I am very pleased today that the first Dr. Stuart Saunders Lecturer is Professor Bernard Gersh, somebody who knew Stuart and Anita as well as their family. And I'm going to invite Dr. Max Price, who is our Vice-Chancellor, to introduce both the lecture as well as our guest speaker for tonight.
Most of you know, but if you're a guest from outside, since this is advertised as a public lecture, Professor Ntubeka Ntusi is the head of the Department of Medicine, and we're delighted to have him leading that department and both the clinical and research programs there. Welcome to everyone, and a special welcome to our guests, Professor Stuart Saunders, Professor Bernard Gersh. This is the inaugural lecture of this eponymous lecture, eponymous because it carries the name and will carry the name of Dr. Stuart John Saunders. And it was endowed by his late wife, Anita, who passed away just over a year ago, a year and 3 weeks ago. And in her will, she left money to endow an annual lecture to both commemorate Stuart's life, but more than that, to reflect the values that he espoused. And when one endows a lecture such as this, it usually serves two purposes. One is to honor an individual, and it is about that individual and recognizing the huge contribution that that individual has made to, in this case, the university as Vice-Chancellor, to the Department of Medicine as the Chief of Medicine, to dozens and dozens of registrars and trainees and undergraduates who he trained, and to thousands of patients who he looked after in his career as a physician and especially as a liver specialist. It's also a recognition of the research that he did, several hundred papers published in his field, which were clearly advancing the envelope of knowledge around liver disease and medicine more generally. So it honors an individual, but it also reminds us of those values that that individual stood for. And Professor Ntusi has already reflected a little bit on Dr. Stuart Saunders' life, but the values he brought in particular regarding non-racialism, challenging the apartheid dogma and practice in the public hospitals, in the universities, in the residences. And he was, of course, the Vice-Chancellor during a seminal period in the country's history from 1981 to 1996, a period which saw us through the 2 states of emergency in the mid-1980s with a huge amount of student unrest and political unrest, and therefore a very difficult time on the campuses where the Vice-Chancellor and colleagues were often inserted in between the police and faculty who were protesting and the security police and police on the other side, and trying to walk, as his biography is entitled, walking that tightrope between pushing the limits of what might be legal so that you didn't set the struggle back, but also pushing the limits in a sense of what might not be legal. There's civil disobedience that would enable, that would assist with change. He was a great Vice-Chancellor. He's fondly remembered, and he went on after his Vice-Chancellorship to work with the Mellon Foundation to support higher education across the country, and his contribution there, I think, will also be part of his legacy. I want to say something about Anita, who chose to honor Stuart in this way, especially given that this is the inaugural lecture. Anita married Stuart after he became Vice-Chancellor, and she had been, and she was all her life, I suppose, an art historian. She had been an academic here at UCT. She continued to practice, in a sense, that part of her life, that expertise. She was on the university's Works of Art Committee. She was engaged with the university extensively, but she really energized the Vice-Chancellorship. She was there with Stuart, supporting him, and through him supporting the university. And I have no doubt that Stuart would attest to the importance of that relationship and of that support in enabling him to do what he did. And all of us as a university are grateful and indebted to Anita, as we are also to Stuart. My wife Deborah and I, who's here in the audience, had the privilege of knowing Anita after I became Vice-Chancellor, so for the 9 years while she was alive, while I was Vice-Chancellor. And we really valued the warmth and the advice, the wisdom, the insight that she offered. A really strong person, no nonsense, and it was a pleasure to be able to share that relationship as well with her and with Stuart over those years. Our lecturer tonight, our inaugural lecturer, is Professor Bernard Gersh, who, born in Johannesburg, is an alum of the University of Cape Town's Medical School, where he got his MBCHB. He then went on with a Rhodes Scholarship to Oxford, where he did a DPhil, and then went on to the US, where he has made a name for himself and a career as a cardiologist. At one point, he was the Proctor Harvey Teaching Professor of Cardiology and Chief of Cardiology at Georgetown University Medical Center in Washington, D.C., and for much of his life and the last years of his working life has been the Professor of Medicine at the Mayo Clinic College of Medicine in Rochester, and has continued his relationship not just with those universities, but with the University of Cape Town and with our Faculty of Health Sciences, coming back many times to teach on a regular basis, but also being involved in the continent, teaching across the continent, across the world, and sharing his expertise. He is really one of our most distinguished alumni in health sciences and in medicine. He's listed by the agencies that measure research impact as what is known as a highly cited scientist, which means that his articles, his journal articles and his chapters and books are cited by more people than almost any other scientists in his field over the years. He has penned more than 650 academic journal articles, more than 125 book chapters. He's the editor of 11 books. He sits on the editorial boards of about 25 scholarly journals, including the journals that most cardiologists would aspire to publish in and would be lucky to publish in: Circulation, Journal of the American College of Cardiology, the European Heart Journal, amongst others. Professor Gersh is also the past chairman of the Council of Clinical Cardiology of the American Heart Association, as well as a former member of the Board of Trustees of the American College of Cardiology. And he currently chairs, I don't know if he currently chairs, he did a couple of years ago when this biography was written, he was the chair of the World Health Organization Cardiovascular Working Group on the ICD-11 reclassification. He's accumulated many teaching and research honors throughout his career. He was listed as Teacher of the Year from the Division of Cardiovascular Diseases at the Mayo Clinic. He received the Hatter Award for the Advancement of Cardiovascular Sciences from University College London. Many of you will recognize the Hatter Institute, the name Hatter from the Hatter Institute, which we have a Hatter Institute in our cardiology department, and there is one in London which we partner with. He has lectured internationally, held numerous visiting professorships, and at a variety of academic institutions. He also is an honorary professor at UCT in our Department of Medicine. And as I said before, it's wonderful that he continues to give back through his regular visits, his teaching, and his assistance with postgraduate research supervision. Professor Gersh is not only, or when we choose speakers, we choose them not only for their academic prowess, but also for the kinds of people they are, the values they bring to the job and to their lives. And I found in an article or an interview with Professor Gersh a wonderful little anecdote which I think highlights this. He was asked, "What is the best advice you've ever received?" And his response was, "The best advice I ever received was from my late father, who was a very ethical businessman. He once said that if you ever think you have a conflict of interest, then you do have a conflict of interest. And therefore all that remains is how you deal with it. It was a lesson in honesty from a simple, clever, and self-made man. It has really driven me. That is the need not to kid yourself, to understand the meaning of integrity, and to stick with it." And I want to suggest to you that in choosing a speaker to give the inaugural Saunders Lecture, we have chosen the right person, not only because he is such a distinguished physician globally, but also because he's an alum of UCT and a very proud son of the University of Cape Town that espouses the values we would also want to espouse. So it's my great pleasure to welcome Professor Gersh to the podium.
I'd also like to thank Ntobeko and Tuzi, and above all, Stuart Saunders, for what is really an honor and a privilege for me to give this inaugural lecture. I worked for Stuart in a number of capacities in my formative years, medical student, houseman, registrar, and ultimately a consultant before I went to the Mayo Clinic in 1979. More recently, my wife Anne and I were very fortunate to be able to spend time personally with Stuart and Anita, and we have very fond memories of that. Now, most people in this room who know me, many family and friends, will be united in stating that I've never been known for my humility. But I want to tell you, you may not believe it, but I really did write to Stuart twice in the last week to say that I thought the invitation should have his photograph on and not mine. Because after all, we are here to honor Stuart Saunders, and not just for what he's done for the Faculty of Medicine, but his principles and values and the courage he showed during a very turbulent time at the University of Cape Town. So I've worked in a number of different areas, and I thought that what I choose to talk on tonight is not just my sort of own research at all, but really to pick a topic that I think is of interest to everyone in this room, and that is the epidemic of cardiovascular disease in what used to be called the developing world, but is now called the low and middle income countries, and the global implications of this, and particularly from an African perspective. So in 2010, these are statistics from World Health. Total deaths in the world were almost 53 million. And of these, you'll see that 15.1 million were cardiovascular and circulatory. And I don't want to decry the importance of HIV, TB, and malaria, but just to point out that 4.7 million deaths, fourfold greater cardiovascular disease. And cardiovascular disease in the low and middle income countries accounts for 80% of worldwide cardiovascular deaths in these countries. They occur at a younger age, which has a huge impact on the workforce and the productivity of these countries. In 2010, 70% of the elderly were actually living in the developing world. And they are poor elderly too. So this is what it means to have a heart attack in a country like India, where there's very little social network. And this is a rather poignant article in The Lancet. Bilal Ryan knows how destructive heart disease is. He had his first heart attack 10 years ago when he was 36 years old. As a laborer who makes a few dollars a day, he could not afford medicines. I have 5 children. They depend on me. I hope they can survive. But him having a heart attack and losing a job, that's the end of schooling for that family in a country like that. What has happened, or is happening, is shown here. The changing distribution of the causes of death in China, a collision of cardiovascular risk factors amidst rapidly growing prosperity. So in 1973, if you just concentrate on the pink and the tan, this is the incidence of cerebro, which is cranial cerebral cardiovascular disease, and cancer, shown here. Look what happened by 2005. This is unprecedented, this unbelievable increase in the proportion of patients that are dying of cardiovascular disease, and given the pollution in China, also cancer. This is something called the New Delhi birth cohort. These are aged 29 to 36-year patients, and I've never seen anything like this. These are the trends and the risk factors. From 1950, they flatten out pretty flat, and then suddenly in the 1990s, 2000, this is the proportion that are now overweight. HTN reflects hypertension and diabetes. Just staggering, absolutely staggering figures that are going to have a huge, and already having a huge impact upon countries like India. Now, to understand what's really happening, I want to take you through what is called the epidemiologic transition, which is a concept that tries to explain what happens to diseases from a socioeconomic standpoint. Stage 1 is the stage of pestilence and famine. Life expectancy, 35 years. Most of the cardiac diseases are due to rheumatic heart disease and nutritional. And this is where the United States was probably from in the 1800s up to about 1880, and Europe maybe 10 years later. But 11% of the world's population, at least in 1986, was still in stage 1. And parts of sub-Saharan Africa are still there. So infections are the major cause of death. Stage 2, which was the US in probably 1880 down to about 1905, was the stage of what's called receding pandemics. 38% of the world are still in stage 2. Now life expectancy has gone up to 50. Proportion of deaths that are cardiac is increasing compared to infectious diseases, but the leading cause of cardiovascular death is still rheumatic heart disease, and now hemorrhagic stroke makes its appearance due to hypertension. Stage 3, degenerative, is called the stage of degenerative and man-made diseases, affects 35% of the world, and this is now the situation in China, Southeast Asia, and many parts now of Africa. Life expectancy is greater than 60. Cardiovascular causes are probably the major cause of death. And now what you see is ischemic heart disease, heart attacks, myocardial infarction. And when these occur, this was around the 1920s, maybe 1930s in the US, initially these occur in the highest socioeconomic groups. And stroke, both hemorrhagic and ischemic stroke, makes an appearance. Stage 4 is where much of the West is now. the United States, most of Western Europe, countries like Australia, parts of this country, and this is the stage of delayed degenerative diseases. At the time in 1986, this was 15% of the world. I would say it's probably more like 25% now. But this is where we are in the US. Greater than 70 is the life expectancy. About 50% of all deaths are cardiovascular. And now ischemic heart disease remains the leading cause of cardiac death. Ischemic stroke and heart failure starts to appear as the third leading cause because people are living into their 80s and 90s. And what is interesting about this from a socioeconomic standpoint is now there's a reversal. So during this phase, it's the wealthier people that get the risk factors that end up with the heart attacks. But in this stage, it is the lower socioeconomic groups that develop premature coronary disease. And if I get called to the coronary care unit and they say there's a 45-year-old woman who's come in with a heart attack, I can tell you her life history, and it's not a pretty one. So these are the ones that lead tough lives, high rate of smoking, various other things, and this is where we are in the States. So a large part of the developing world, if I can call it that, or the newly industrialized nations, Eastern Europe, China, India, parts of Southern Africa, are in stage 3, and we're now in stage 4. Now, this is an interesting study that illustrates it, that a number of us published. It's a registry of about 60,000 patients, and with risk factors for cardiovascular disease, and we stratified them according to the level of education, from 0 to 8 years all the way to university and college. And these were the associations with attained educational levels. So in the high-income countries, like the US, the higher the level of education, the less the obesity, less smoking, less hypertension, less diabetes, more hypercholesterolemia, and less disease in more than one vascular bed. But in the lower and middle income countries, it's a different pattern. The greater the level of education, the greater the amount of obesity. Smoking is about the same, except amongst younger women in these countries, it's gone up. Hypertension's the same. Less diabetes, but more hypercholesterolemia, and much more extensive disease involving more than one vascular bed. So this really explains how the risk factors behave differently according to whether you're a high-income country or a low-income country in terms of their association with educational levels and by implication income. Now, this study done by Crystal Steen from Stellenbosch and Karen Sliwa from Cape Town is an analysis of myocardial infarction in Africa from a very large study called the Interheart study and its relationship to socioeconomic status. And it's the terminology here, by the way, black Africans, colored Africans, and Europeans and other is the terminology that was used in the paper. And this relates to formal education on this graph, and this is income. So if you look at Europeans who are in stage 4 of the epidemiologic transition, the greater the level of education, everything below the line, for the non-physicians here, anything below the line would be that the likelihood or the risk of myocardial infarction is reduced. And anything above the line, it's increased. So if you take whites or Europeans who are already in stage 4 of this transition, the wealthier, the more educated they are, and the wealthier they are, the less the risk of heart attack. But if you take black Africans who are now newly into the middle class, the more educated they are and the higher the income, the greater the risk of heart attacks. And where you see this very strikingly, I've spent some time in Kenya, and they have a Swahili phrase called wabenzi. A wabenzi is he who drives a Mercedes-Benz. And if you go into the hospitals, those are the people that are getting the heart attacks, not the Maasai wandering around on the plains of Kenya. It's the new empowered middle class, and they're getting the heart attacks. And that's what's happening right now in South Africa, and I'll show more of that. Now, this is more complex. Spouse behavior and coronary heart disease in men. And this is from the epidemiological study in the States called the Framingham study. I want you just to concentrate here on the level of education of the husband and the wife. So if you take a husband with 9 to 12 years of education who is married to a woman with greater than 13 years of education, his risk of heart disease is double than if he marries one with less than 8 years of education. So I've discussed this with my wife and 4 daughters, and I've been advised not to give an interpretation because I've got some theories about it. Actually, if you look at the paper, it was written in 1983, it's very interesting. It may be related to stress among professional women in the workplace as they entered it in the 1980s, and stress then being carried on into the home. Be that as it may, it is actual real data. So phase 5. Is there such a thing as phase 5, where all the gains and the benefits are now lost in terms of cardiovascular mortality? What is going to be the impact of social upheaval and health regression in some of the newly developing countries? And what about the age of inactivity and computer games and obesity? What effect is that going to have on cardiovascular disease? And these are sobering and disturbing data that came out from Russia on life expectancy. If you look at US females in yellow and Russian females in orange, and US males in green, Russian males in orange, what you see is that life expectancy improved, was continuing to improve, even though it was lower amongst Russians than amongst the West. But then something happened. And you can see here, life expectancy starts to go up and then crashes. And the same thing with Russian females, but not with the US. And what happened? This was Gorbachev's anti-alcohol campaign and so-called perestroika, which was an optimistic time in Russia. This was the collapse of the Soviet Union and a period of economic and social instability, increased alcohol, increased tobacco, very little investment in healthcare, actually. And so what happened at this time were people who had never existed outside the communist system are then thrown out in the streets, and they have to now compete in an area of extraordinary capitalism. And this is what happened to their longevity, which is the greatest ever seen outside a world war. And Russia lost 22 million in World War II. And what were the deaths due to? Heart disease and stroke accounted for 65% of the decline in life expectancy. And the second leading cause of death was alcohol, violence, and accidents in the workplace. Now, I have seen interesting data from St. Petersburg that shown that this was not noted in university graduates. It was really people who worked in the communist factories under that state system who now had to go and fend for themselves. These are worrying data from the Center of Disease Control in the United States. If you look at age-adjusted mortality from 2000 to 2014 for cardiovascular disease, it's flattening off. Cancer, it's continuing to decline. There's still a gap between the two, but the drop in mortality, which we've been seeing since 1967, appears to be leveling off. And it decelerated substantially after 2011, both in males, females, whites, blacks, all ethnic groups. Still greater cardiovascular mortality than cancer, but the concern is that now in the era of inactivity, weight gain, and obesity, is diabetes going to wipe out many of the gains that have been achieved in the United States and the Western world over the last 40, 50 years? What about the risk factors for cardiovascular disease in the developing world, both traditional and novel? And this is an important paper from Professor Salim Yusuf, and illustrates the risk of acute myocardial infarction after adjustment for age, sex, and geographic region. Everything to the right of the line would suggest if you have any of these risk factors, the risk of myocardial infarction or a heart attack is increased. And this is in females, and the orange is or tan is in males. Everything to the left of the line would suggest that a beneficial effect. This is interesting. It's called a psychosocial index, which is a marker of stress and socioeconomic status, and it's very high in the developing world. And these are the beneficial risk factors, so-called. Diet, fruit, vegetables, moderate exercise, moderate alcohol, all reduce myocardial infarction. And this is smoking, diabetes, hypertension, abdominal obesity, and so on. So what we learn from this is that all 9 risk factors accounted for about 90% of the population attributable risk, which is a term that is used to assess the various components of risk in a population. And what it does tell us is that the same risk factors apply all over the world. So we know what the targets are for prevention and treatment. But the developing world has other issues that are unique to it. And this is from a paper written by myself, Karan Sliwa, Bongani Mayozi, and Salim Yusuf. And what we described in the developing world is a perfect storm of predisposing factors. What you have is a very hostile cardiovascular environment. Diet, lack of exercise with its effect on diabetes. Tobacco, including secondhand smoke, incredibly high in countries like many of the Asian countries, China, an aging society. And we now also have long-term survivors of HIV, and what we're starting to see in the United States is premature coronary disease. And these individuals as they get to their 40s and 50s. And it was interesting, I heard again recently in Kenya that one of the physicians said, we're starting to see very early heart attacks in some of our patients who've been on retroviral therapy for the last 15 years. So this is a problem that is still coming. What about air pollution? And I'll have a few things to say about that. The other thing about these various countries is there's been this tremendous rural to urban migration. If you look at Africa, 5% in 1900 lived in the cities. In 2015, it's 45%. And you can just see it for yourself as you drive down to the airport on the, whatever it is, N2 or whatever. But, and you see this again in countries like Kenya. So this rural to urban migration also brings with it tremendous social and economic stresses in countries that may also have a different culture. You know, in many societies, in some African societies, being too thin is not a good idea, and being obesity is a sign of wealth, but it's also a sign of developing diabetes. So there's a clash of cultures. And then for most of the developing countries, there are limited national resources. There's a lack of infrastructure. And this is called the thrifty gene concept, and I won't deal with it in any detail because it is still a concept, and I put a question mark there. But the theory is that certain races or certain indigenous populations are simply not programmed to deal with the modern world. And the example being Australian Aboriginals, who have a life expectancy 19 years less than a white Australian. Some of the American Indian, Native Americans have incredibly high rates of diabetes. You see this up in the Arctic with the Inuit people. And this is called the thrifty gene concept. And effectively what they say is if you're in fact on the edge of starvation most of your life, it's not a bad idea to be insulin insensitive because it pushes your blood sugar up. If we get insulin insensitivity or resistance, then we get diabetes. So this is a fascinating concept, but it is just a concept. What about air pollution? This was the first report in 2004 from the American Heart Association that said air pollution is a powerful risk factor for coronary disease. 2014, another statement, the body of evidence has grown and been strengthened substantially since the first American Heart Association statement was published. Recently, an expert position in the European Journal of Cardiology on air pollution and cardiovascular disease. Do any of you recognize this building? This is the Bird's Nest Stadium in Beijing. This was taken 3 weeks before the Olympic Games. And I went for a run and I thought I was going to die of bronchitis for the next 3 weeks. What then happened, and you can only do this, I think, in a totalitarian state, they banned all traffic. Just like that. They closed the factories. And then they were lucky. They got some thunderstorms and they had a blue sky Olympics. But this is what it looks like most of the time. And when you fly out of Beijing, you fly out of this yellow cloud and then you see blue sky. So when you look at if I just go back here, if you look at the 40 most polluted cities in the world, one is in Africa, Cairo, the rest are in Asia. And this is a powerful, powerful risk factor. So the thrifty gene concept, Dr. Gregg of the Rockefeller Foundation made this statement: the human race has had long experience and a fine tradition in surviving adversity. But we now face a task for which we have little experience, the task of surviving prosperity. And you realize that the Western world has not been wealthy for long. I mean, 200 years ago, America was a very rural country. And so we've had maybe 200 years to survive prosperity or face prosperity. But for some of these indigenous tribes, they just haven't had that long because they are only now starting to experience some of the, quote, benefits of welfare and giving up their, particularly like in the Inuits who always survived by hunting seals now live off welfare, and the diabetes rate is just going through the roof. Well, in Africa, billion people, 1 million deaths, cardiovascular deaths in sub-Saharan Africa, 11.3% of all deaths in Africa, 38% of all non-infectious deaths or non-communicable disease in Africa. Since 1990, almost twofold increase in overall cardiovascular-related deaths, and diabetes is going to double in the next 10 years. So this is a catastrophe. Interesting, and there are many explanations for this. There's a greater than 10% mortality difference in women greater than versus men, but that is another topic, and it probably relates to access to care and other factors. Here's the other problem, and that is the shortage of physicians. So this is doctors and nurses in South Africa compared to the USA and the UK per 100,000 population. Malawi has 1 doctor per 50,000 of the population. And so how is one going to deal with this epidemic? And we'll talk more about it. In HIV survivors, this is a study from Botswana, and it shows the risk factors that are present in 500 HIV long-term survivors. Hypertension in yellow, dysglycemia, which is an abnormal blood sugar in orange, dyslipidemia, hypercholesterolemia in green, obesity and smoking. All of the risk factors are there. Waiting, they're all there, with one exception, and that's hypercholesterolemia is not there yet, but it's coming. And so when you deal with a population that may be particularly vulnerable from a vascular standpoint for cardiovascular disease, and now you throw in the risk factors, you can see the potential for an epidemic, because no risk factors, no coronary disease. And we know that the same risk factors apply all around the world in terms of the development of cardiovascular disease. And urbanization is coming, and believe me, American industry is more than happy to exploit anybody. And so hypercholesterolemia is here, diabetes is already here. What is interesting is, how long has coronary disease been around? And there's some interesting statements. This is probably the oldest papyrus, the Ebers papyrus from the ancient Egyptians. Shouldst thou examine a patient with stomach disease, suffering from pain in the arms, in the breast, and on one side of the chest, say death threatens. It's a pretty good description of angina. This Heberdin in the 1760s described a disorder of the breast consistent with angina. And then the Guy's Hospital physician, John Hunter, said, "My life is in the hands of any fool who manages to put me in a rage." And when he did, he experienced angina. And he died of a heart attack after an argument at St George's Hospital, London. What I'm told, and I particularly like, but I don't know how, whether it's true or not, is that he had an argument with a hospital administrator. And I think that could put any... So one has to be sympathetic. So it's been around a long time, but how much it was there? And in the 1920s, there wasn't a great deal of coronary disease in the UK and the USA. The epidemic really started in the 30s. So this is from Osler's Principles and Practice of Medicine, 1912. Angina pectoris, it's a rare disease. A case a year is about average, even in the large metropolitan hospitals. Now, let's say they underdiagnosed it by tenfold. It's still, and Osler was basically developed the Department of Medicine at Johns Hopkins, as well as spending time at Oxford. And then prior to World War I, there was an autopsy study from the UK at the London Hospital. 1 to 2 patients per year with recent coronary thrombosis, acute myocardial infarction. Well, let's say again, they underdiagnosed it by tenfold. But we've seen exactly the same thing at the Mayo Clinic. We've got autopsy records going back to 1920, and in fact to 1912. And we have a paper in press right now that's going to show that really deaths due to heart attacks in 1920 were uncommon. And this was another autopsy study from about 1944, and now they saw a 7-fold increase in the number of cases of coronary heart disease. Now, this is a quote from Paul Dudley White, a much revered and a famous American cardiologist who worked in Boston. And remember, I did say earlier on that when the disease, the epidemic starts, it hits the well-off first. It's only later in the course of the epidemic that it's the lower socioeconomic groups that get it. But initially, it's the wealthy that get it. So this is Paul Dudley White talking about Boston. "The disease in my youth was hardly a problem, but I know that my professors did have occasional cases among their well-to-do patients whom they cared for at home." And then 20 years later, in the 1940s, the epidemic was raging and out of control. You can avoid coronary disease. This is a fascinating paper published by a friend of mine who got funding to take a CAT scan down to Bolivia. And they scanned the Somali Indians or Bolivians. They scanned them for calcification of the coronary arteries, calcium in the arteries, which is a marker of coronary disease and atherosclerosis. This is how they live. This is what they eat, fish, and all the meat they eat is wild game. They don't have coronary disease. And what is incredible is to see the comparisons in this study in arterial calcification between the Somali Indians and an American population. Even at the age of 90, these people don't have coronary disease. And it's not just because they don't live long, they do live long. So it's a really interesting example that an extreme example, but coronary disease is not ubiquitous. This is an old study called the 7-country study that dealt with a number of parts of the world. And shown here, if you just concentrate on a cholesterol of 5.1, shown here on this axis is the mortality from coronary heart disease. This is Northern Europe, and the green is the United States, and this is Japan. So if you have a cholesterol of 200 or so, 5.15, in Japan, you have a rate of coronary disease under 3%, coronary disease mortality, whereas in the United States, it's three times that. And you could actually argue, if you look at this curve, why bother to reduce the cholesterol in Japanese? Well, this is a 25-year-old study, and it's starting to look different. There is an increase in coronary disease in Japan, but it's still far less than we have. But raised the question about whether certain populations are genetically predisposed or genetically favored. I think it's probably a matter of time, and it relates to the risk factors, which were less in Japan than anywhere else. But it does raise that question. And Dr. Elliot Joslin of the Joslin Diabetes Clinic made this statement: genetics loads the gun and the environment pulls the trigger. Now, there's a lot of discussion in India and in the UK, and in this country for that matter, about whether genetically South Asians and Indians are predisposed to coronary disease. And it's an argument that goes back and forth. Certainly, if they do not have risk factors, they won't get coronary disease. But I think when they do get the risk factors, they get a more aggressive and violent form of coronary disease. And for those of you who do coronary angiography, this is a 35-year-old male that I saw at the All India Institute of Health Sciences. And for those who are not cardiologists, let me tell you, these are inoperable coronary arteries. This is about as bad as coronary disease can get. These little spider, these are the arteries. You can't operate on them, you can't bypass them, you can't stent them, you can't do anything. And the only other time I've seen angiograms like this is in Durban, in the Indian population. So I think genetics may load the gun, and if they can control the environment and lead, the healthy lifestyle that we would like, they won't get coronary disease. But when they do, there's an ignition and an explosion. And what happens genetically is interesting and still being investigated. Carr and Slewa published this very important paper called the Heart of Soweto Study in 2008. 1.1 million people estimated, 85% black, mean age 52.8. Cardiovascular risk factors, 87%. And during 2006, there were about 1,600 new cases of cardiovascular disease. And if you look at coronary artery disease, only 6% of blacks with new onset cardiovascular disease had coronary disease. What was much more common was heart failure due to hypertension, HIV, valvular heart disease, rheumatic fever, and hypertension. But only 6% of new cases of coronary cardiovascular disease occurred in blacks. Now, this is a former All Black who said, if history repeats itself, I should think we can expect the same thing again. And that is exactly what is happening. And it's even more rapid than we expected. If you go to Baragwanath Hospital now, 95% of ICU beds are occupied by people with acute coronary disease. So, talking to Karan just last night, I said, we all thought that this would happen, that coronary disease would come, but not this quickly. And this is what's happened in Kenya and other places. In 10 years, this epidemic is now raging in full force in South Africa amongst black Africans, as well as obviously in China and India. Now, the Framingham study was a very important study initiated in the United States, I think in the early 1950s or 40s. And Framingham is a population outside Boston that is mainly Caucasian, middle class, and they were studied in depth and still are. It continues. In 1961, they published the first 6-year follow-up report. And what the Framingham study said, hypertension, high cholesterol, and smoking are the risk factors that are causing the epidemic of coronary disease in the United States. Because it was raging, but then it was very high in 1961. Almost immediately, the National Institute of Health, American Heart Association, and then the Surgeon General's report on smoking were published. And immediately steps were taken. And within 4 years, the mortality or the death rate from coronary disease started to fall and has just continued to fall since then. Starting to level off now, as I pointed out, But that was the change. And by 1965, 67, the size of the epidemic was declining. And Gene Brownwald said, and I think this is a good statement, the Framingham study provided the NIH, the country, and the world with a huge return on its investment. Because we learnt what the risk factors are and we knew the targets. And now the challenge is is in getting people to have access to care and to stay on their drugs and treat them, because I don't believe the Banting diet will solve hypercholesterolemia. But it's an emotional issue in South Africa. So what has happened in the States, and this is a really interesting study, of 3 autopsy series of mean age about 22.1. So these were US service members who died either in combat or from accidents. And I want you just to focus in orange on any atherosclerosis, because these are only 22-year-olds. 77% in the Korean War, 45% in Vietnam, and in the Gulf War, 8.5%. I mean, it's really going down. It's not just the death rate that's going down. The amount of coronary disease is getting less. And if you look at severe atherosclerosis, this was 15% of 22-year-olds in the Korean War already had significant coronary disease. Severe, now 2.4%. And so it really does show that one can make a difference. And this is an important study from Dr. Ford and published in the New England Journal of Medicine. And what he did, he looked at a whole series of studies around the world and basically did a statistical model and said, what proportion of the reduction in deaths due to coronary heart disease is attributable to treatments or changes in risk factors? And I want you to focus on Poland and then also on Finland, because Finland, Eastern Finland, had the highest incidence of coronary disease ever described anywhere. So yellow are drugs, orange are risk factor modification, green is unknown. And it's difficult to sort out treatments from risk factor modification, because where do you put statins for that matter? I mean, does that come under risk factors or does it come under drugs? But be that as it may, you can see the bulk of the effect on reducing deaths was the modification of risk factors. And Poland and Finland is an amazing example. A 73% reduction in the death rate due to coronary artery or ischemic heart disease from 1995. 25 years it took them. And there was a major change in diet, smoking, hypertension, disciplined population, 73% reduction in death rate. So again, we know what the targets are. So the temporal course of the epidemic, I think what we've learned is it can progress incredibly rapidly. But I want to show you some more optimistic data that control can have surprisingly early and positive benefits. So this is a study from a woman in Australia, Catherine ODay, from Derby, Western Australia. I've been to Derby, which is without any doubt one of the more unpleasant places in the world. The amount of alcoholism is unbelievable. If you walk down the roads, you're going to get run over. And if you go and walk on the beach, you get eaten by crocodiles. And what they tell me, what some of the inhabitants tell me, is that even the crocodiles, the saltwater crocodiles, are alcoholic. So what she did was she took these 10 Aboriginals, or Indigenous Australians to be politically correct, and sent them back to the bush for 7 weeks as hunter-gatherers, carrying a kangaroo, spearing fish. And by the time they came back, the major metabolic abnormalities of diabetes were either greatly improved or completely normalized. 7 weeks. The other study comes from Cuba. And when I first saw these data, I thought they were too good to be true, and I didn't believe it, but it is true. So between 1989 and 2000, Cuba had an economic crisis. The United States was continuing its blockade. The Soviet Union had collapsed, and it was the Soviet Union that was keeping Cuba afloat. And so suddenly everything changed. They had very little petrol, they had to walk more, they had less food, they smoked less. And look what happened to type 2 diabetes. So shown here in the dark is the period when the crisis was at its worst. And this is on either side. Look what happened to diabetes. And then look what happens now. And I'll come back to that. Coronary heart disease mortality. And remember, Cuba does have very good health statistics. Coronary heart disease mortality was sort of going down, and then it really goes down. And now it looks like it's picking up. Cancer stayed the same. All-cause mortality went down. So I think our blockade, we did Cuba a great favor. And I don't think that was those weren't the altruistic reasons for blockading Cuba. But now look at what has happened in this same author. Shown here is the prevalence of obesity in blue and the prevalence of diabetes in yellow. Incidence is new disease. Prevalence is disease that is just prevalent in the community. And here again, if you look at the recovery period, you see that during the crisis, obesity went down and now it's gone up. The prevalence of diabetes, fairly stable, now it's gone up. Now, if you look at new cases of diabetes, you see the same thing. This is the obesity, and now look at new cases of diabetes. Look how quickly it comes about. Quickly. Doesn't take long, a few years. And if you now look at mortality from diabetes in green, there's a lag because it takes time for the disease to become manifest and cause complications. But if you look at mortality, it was going down and it's now going up. So these changes can take place very rapidly indeed. So to close, what can we do about it? And there are two main strategies. One is to treat populations. And the World Health Organization has identified, quote, the best buys: tobacco, alcohol, diet, salt, sugar reduction, physical activity, and replacing trans fats with polyunsaturated fats. Now, this has happened in the state of New York, in several counties in New York. And it is interesting that those counties have now published a follow-up. The rate of myocardial infarction has gone down. If you could get rid of one thing, it would probably be tobacco. Now, there are all kinds of issues, because if you look at China, the major manufacturer of cigarettes is the Chinese government. So there's a conflict of interest. But what this approach tells us is that who are the target audience? I mean, to bring this about, you really need social engineering. I mean, it's all very well to say, you've got to go and exercise. Get out and exercise. I was in Mumbai 3-4 days ago, and the temperature was about 48 and the humidity 100%. And it's not exactly a city covered with parks where you can exercise. So if you're really going to do this, and the World Health says they're serious about it, and the United Nations says they're serious about it, it's not just going to be up to doctors and nurses. You really have to get into social engineering and involve industry and legislators. You know, taxes on sugar, clean air, clean environmental management. All of these are going to be part of reducing the epidemic. The other option is to just intervene in high-risk populations with statins, other drugs, blood pressure control. And there's a lot of interest in the so-called poly pill, one pill that has an antihypertensive, a statin, and aspirin. And it remains to be seen in 2 trials what's going to come of this. So I think both strategies are important, and they talked about a lot, but the question is, are we going to see action? Because it can't be done unless governments really want to do this. Bill Gates' statement, humanity's greatest advances are not in its discoveries, but in how these discoveries are applied. Technology is evolving. What's going to come up in the next 10, 20 years is mind-blowing. The biggest challenge, though, is at the moment about 1.5 billion people in the world are getting good health care, but there's another 6 billion out there not getting any, or very limited. And that's going to be the real challenge from a socioeconomic standpoint. How do you deliver care? This is the social scientist, Deming. He said it's not necessary to change. Survival is not mandatory. But we know that our current systems of care are simply inadequate. Even in the United States, there's huge differences between Minnesota, where I work, and Mississippi and the Appalachians and West Virginia. Huge differences in the quality of care and the quality of health. And, in Kenya, if you have a heart attack near the Aga Khan Hospital, you'll be treated with stenting within an hour. If you have it out in rural Kenya, you're not going to survive. You're not going to get any treatment. So it's the way in which we deliver care is going to have to change. And what's going to happen in the future, and what are the questions? Well, Dan Quayle was our 46th vice president, and he was not known for being an intellectual giant. He said predictions are risky, especially about the future. But I want to tell you that Tony Blair also got it wrong. I don't like making predictions. I never have, and I never will. But I think that there's general agreement, as I close now, with a couple of, I think, principles that people agree on. First of all, we have to understand the data. Most low and middle income countries exist in what I would call an epidemiological data-free zone. We don't have any data, and reliable data are a priority. And unless you have the data and the information to tell you the magnitude of the epidemic, you're never going to be able to measure whether you're getting on top of it or reducing it. And what South Africa needs is an African Framingham study, like the one in the United States, particularly, and I know Ntobeko and Tuzi is very interested in this. And I think what you need is to study two populations, one that is stable and another that are migrant, that are moving in. We have to understand the burden of disease. It's interesting that in Rochester, New York, they have much better data on the number of cars that have been stolen than on the number of people with diabetes. And then one needs improved country and region-specific databases. What's happening in Africa and the United States are two completely different entities. The other solution, and I'm working with a friend and a colleague. I have a joint appointment at Duke University, and we're working on submitting a grant for a systems approach. Now, what we want to do is utilize, or not us, but the grant is going to be to utilize the systems of care that are already there for HIV. So in a country like Kenya, every single county has an HIV center. Why can't you use that infrastructure and add onto it the ability to treat hypertension, diabetes, atrial fibrillation, and anticoagulants? We should be able to do that. The Kenya government is very interested in this model. And it can be done with nurses. The most expensive way of dealing with the disease is trying to train more specialists and send them in the rural areas, because they're not going to stay there. What about innovation? And this is what is exciting. Einstein said, if you always do what you did, you'll always get what you always got. And Deepak Chopra says we have approximately 60,000 thoughts in a day. Unfortunately, 95% of them are thoughts we had the day before. So the time is ripe for innovation. The iPhone, the iPad, the iWatch, multiple applications for primary and secondary and even primordial prevention. And then Elon Musk, solar power, lithium-ion batteries. And Africa, 1.17 billion people, probably the highest penetration of cell phones in the world. And in Kenya, the number of internet users grows by 20% per year, higher than any other part of the world, the growth. So these technologies are going to change the world. With a smartphone, this is an echocardiogram. Incredible. Quality, excellent. Smartwatch electrocardiogram. Smartphone glucose levels. And of course, what is so interesting and what's so relevant is that many of these diseases can be managed by someone sitting in a room in Cape Town taking care of people hundreds of miles away. In Rwanda, the president is very interested in technology. The transformative impact of technology on care delivery in Rwanda. Now, Professor Marisco is the inventor of the laparoscopic cholecystectomy, and has really led a surgical revolution in many ways. And what he's now done is established an digital training center for endoscopic surgery in Kigali. But what is interesting about this center is they're using digital technology and also robots and robotic surgery. And you may know that the birth of robotic surgery came about at a think tank where someone posed the question, if we're going to send a man to Mars and that person gets appendicitis, what can we do about it? And this is the idea behind the center, is that maybe robotic surgery will be done many miles away from the referral center, because they certainly can't build 100 referral centers. The mobile phone, Rwanda's weapon for distance surveillance of high-risk pregnancy. And then Rwanda's hospitals use drones to deliver medical supplies. Pretty interesting, isn't it? And I don't know if you've seen the data now on drones that are going to come to victims of out-of-hospital arrest. They'll be able to summon a drone that'll come and treat them right there on the spot. So my closing slide is why rich countries should care about the world's least healthy people. First of all, it's very much in our national and international self-interest. Poor, unhealthy countries, there's no trade, there's no productivity. And it's very much in our interest and the world's interest. And the United Nations say they recognize this. But it's in our interest to have stable, healthy populations around the world. The other is, as you know, President Trump has expressed a complete lack of interest in Africa and in aid to Africa. But one of the arguments that's going to be used is the United States has already invested heavily in global health, invested heavily in malaria, TB, HIV, and AIDS programs. And if we want to protect our investment, why should we have spent all this money for people just to die early of coronary disease? So the argument is you've got to keep investing and protect and build on the investment we've made. And then there is the moral and the ethical obligation, which is clear-cut. So this is my concluding slide. At this United Nations Summit in 2011, they discussed two new economic studies. The World Economic Forum said from a global standpoint, the cost of business as usual is 47 trillion over the next 25 years. The cost to the low and middle income countries is 500 billion or more per year. World Health Organization states that the cost of basic prevention at a primary care level in low and middle income countries is 2 billion. The cost of basic secondary prevention and treatment is 22 billion. Contrast that with 47 trillion. So much is spoken about this, and hopefully we will see action, because there is no question that the developing and the high-income countries are going to have to play a role in the transformation of healthcare around the world and in Africa. Again, it's a great honor and a privilege for me to be the inaugural Stuart Saunders Lecturer. Thank you.
So the lecture is going to be unopposed, and there'll be an opportunity for people to interact with Professor Saunders and Professor Gersh afterwards. But I'd like to invite Professor Saunders to say a couple of things.
Thank you, Bernard. Before I do that, I'd like to say how thrilled Anita would have been about what's happened here this evening. She would be absolutely thrilled. Bernard Gersh is one of the top cardiologists in the world. He's a product of the Department of Medicine of UCT, and he really has delivered an outstanding lecture here tonight. Thank you very much indeed, Bernard. It was superb. Thank you. I also want to thank Professor Ntusi, the head of the Department of Medicine, for all he has done to make this evening possible. His warmth and friendship and his outstanding leadership of the department, which is the jewel in the crown of the university, the biggest department in the university, producing the greatest amount of research in this university, and his leadership is inspiring in the department. So thank you very much, Professor Ntusi. And finally, I want to thank the Vice-Chancellor, Dr. Max Price, for all he did to make this evening possible and for his friendship and leadership. Thank you very much for being here. I want to finally thank you all for being here. Thank you.